E ngā mana, e ngā reo, e ngā karanga maha o te wā. Tēnā koutou, tēnā koutou, tēnā tātou katoa. Ki ngā mana whenua, ko te Aotearoa, Ngāti Toa, anō nei aku mihi ki a koutou, te kia kaurua. Ki tēnei whare, ko te Papa Tongarirua, tēnā koe. Noko te honore kia haere mai ki te whakanuia tēnei huihui ngā whakahirihira. Nō reira, ngā manaakitanga ki runga i a tātou. Tēnā koutou, huri noa i te whare, tēnā rā koutou katoa. Firstly, thank you, Professor Barclay, for the introduction and for leaving plenty of time for questions at the end. I do have to rush away. I quite enjoy questions. As you know, my media minders don't. They tell me I should spend more time talking and less time answering questions. I'm very pleased to have the opportunity to address you for the second time at your annual conference. When I first had the pleasure of addressing you last year, I had been a minister for 28 days. And while I'd been health spokesperson alongside Annette King for a few years before that, I still had and still have plenty of things to learn about being a minister. And on that previous point, one of them was just how many parliamentary oral questions an opposition can construct from just one video recorded at ASMS Q&A session. Quite extraordinary. I think I had 2 months of questions derived from that Q&A session. Which is great. I mean, people are obviously watching, not least of which the opposition. It is timely to reflect on the concrete actions of government 1 year on. The coalition government has over the past year responded to some of the challenges faced in our health system. I'd like to, though, acknowledge from the outset Ian Powell and the current and the past members of the ASMS executive. I'd like to acknowledge ASMS delegates, international guests and other speakers who are here in the room. And I want to acknowledge the important contribution and dedication and commitment of ASMS to and your whole wider membership to our public health system. I want to thank all of you from the outset for the top quality care that you provide in your roles day to day for so many New Zealanders. Over the past year, I've had the privilege of meeting more of you and building relationships and having conversations with you. I do firmly believe that a successful health sector involves good relationships across the board. I'm grateful that so many of you have taken the time to share your views with me, and I believe that is the way to strengthen our public health system. Ministers of health are only as good as the people they speak to. And we all face many challenges, and while I haven't been able to solve all of these challenges in my first year, and I might not have always agreed with all of your views, I think it's important that those lines of communication are strong. Last year at your annual conference, I outlined my vision for a strong and sustainable public health system and the challenges our newly formed government faced in addressing 9 years of underfunding in health. That underinvestment and the last government's fiscal priorities meant that they effectively stripped out $2.3 billion from the health budget. A year ago, I told you that the then new government was committed to putting an additional $8 billion into health over the next 4 years to strengthen our public health system. We have begun, as we intend to continue, investing $3.2 billion into health in our first budget alone. We committed to ensuring New Zealand's public health system is strong so that people nationwide can access quality health care that they need and deserve wherever they live. Ultimately, no health system, though, can be effective without a capable, well-resourced and well-supported workforce. As a union, ASMS has been vocal about its concerns with the state of the senior medical and dental workforce in our DHBs. I don't ever make an announcement about addressing the state of our buildings without receiving an immediate response off the press from Dr. Ian Powell. commenting on the need to make sure that we also address workforce issues, and I take that incredibly seriously. As I acknowledged when I spoke in our last conference, underfunding places a massive strain on staff in the health system. The effects of that pressure have been explored in research by the ASMS, and the 2016 study found that half of the 1,500 ASMS members who participated reported symptoms of burnout. It also pointed to a strong correlation between burnout among SMOs and the hours they worked. And I also note yesterday's media reports of research by Dr. Charlotte Chambers of the ASMS, which highlights how much of this pressure is coming to bear on the female members of the profession. As demonstrated with the settlement of the NZNO bargaining, the government is willing to work collaboratively with DHBs, unions and clinicians to ensure workload concerns in our public hospitals are addressed and to develop a range of constructive responses. The Health Sector Relationship Agreement, the HSRA, which involves the Ministry of Health, unions and DHBs, remains the principal forum through which we can maintain a high-level dialogue focused on our shared interests in a high-performing public health system. Recently spoke at the Resident Doctors Association conference on resident medical officer health and well-being. As many of you will know, the NZRDA has a history of robust advocacy for its membership. I'm aware that a key issue in its current negotiations with the DHBs is the impact of the safer rostering provisions agreed in the last MECA. And I'm also aware that one of the unintended, if not unforeseen, consequences of that settlement is the impact the new rostering rules are having on some SMO workloads and the functioning of medical teams. At a time when we all recognise the importance of physicians attending to their own health, to me the lessons from this is not to focus on narrow solutions. The Director General has a proposed forum on the future medical workforce, and I see that as an opportunity to start a wider discussion with a broader range of stakeholders to ensure sustainable and enduring solutions to the challenges facing the medical profession in this country, including workloads. I'm confident ASMS and its membership can make a positive and constructive contribution to these discussions alongside other unions, the NZMA colleagues, the Medical Council and DHBs, and I encourage you to do so. Throughout my first year as Minister of Health, I've learned many health facilities around the country are in even more dire situations than I had previously understood. Some of them are earthquake prone, some are leaking buildings, some are well publicised, have rotten mould in their walls, and all of this is a legacy of neglect, and I think partly a symptom of the fact that we haven't had good arrangements around our capital infrastructure that tell us when they will need replacing, that we have never had any baseline data. We don't have an asset management register in New Zealand for our health system. Most businesses with a few $1 million would know what their assets were and when they would need replacing. We have no standardised data across our health system that tells us billions and billions of dollars of assets when they need replacing and what state they're in. Now that is a piece of work that I have asked for very early on in my time as Minister. It's one that I'm sure many future Ministers of Health will curse me for, but it will actually map out the implications for future years that present themselves if we wish to maintain the standard of facilities that you work in across our public health system. We cannot fix everything in one budget, but improving the state of our hospitals and health facilities is a clear priority of the current coalition government. In our first budget, we put in $750 million in capital works funding. To give you a sense of the scale of that, the prior government in their largest year of investment put in $450 million, and that was a direct response to the Canterbury earthquakes. For many of the years that they were in government, they put no extra funding into their capital envelope. So in our first one, we put $750 million in. We recognise we're going to need to continue to invest. The best estimate at this stage from the Treasury is that about $14 billion is going to need to be spent on our assets over the next 10 years in our health system. So this is a challenge that we are taking very seriously. The National Asset Management Plan, when it lands on my desk sometime very much towards the end of next year, I expect at this stage, will make that whole picture plainer, and we will then have a plan as to how we ensure that we have high quality facilities into the future. But we have set about, in the meantime, investing already in those situations which are most obvious to us. Of the 750 million, last week with the Prime Minister, the Right Honourable Jacinda Ardern, I announced $80 million of funding for Counties Manukau to address building issues there and to make some necessary changes. We have allocated about 600 million so far of that money, including 275 million for Auckland DHB to address significant infrastructure challenges at the City Hospital and Green Lane Clinical Centre. An estimated 200 million has been allocated to an elective surgery facility in Waitemata on the North Shore. 45 million has been allocated to the new Children's Hospital. We've had to top up, it's 23 million we've added into that to get that project across the line, supported by a local donor. 24 million for the new endoscopy and cardiac care capacity at Northland DHB's Whangarei Hospital. 20 million for the new Bulla Health Centre. 8 million for Capital and Coast DHB for individualised service units for our most high needs intellectual disability and mental health patients, and $7.1 million for the Phase 2 redevelopment at Bay of Islands Hospital. So, as I said last week, upgrading and repairing hospital facilities is no small task. It requires careful planning to minimise disruption to patients and staff. And I do want to thank all of you, because we are going to be doing building, and it is going to be at times disruptive for all of you. And I want to thank you for the services that I know that you will continue to provide, and the care you will continue to provide in that situation. I spoke to you also last year about my commitment to improving equity and access to healthcare for all New Zealanders nationwide. It is central to the Coalition Government's priority outcome of supporting healthier, safer and more connected communities. I want to ensure that the public health system delivers high quality, accessible services for all New Zealanders. As I've always acknowledged, our health service has many strengths. It is looking after New Zealanders well, especially when we are acutely ill or injured. We have world-class clinicians, and many of you are in the room today who are at the top of your field around the world. You deliver high-quality care across a range of specialties and disciplines. And the commitment of you and your colleagues remains critical. I want to acknowledge the importance of primary healthcare services in achieving health outcomes we aspire to as a country. Access to timely primary care assists in maintaining wellness and good health and keeping people out of hospital. When I spoke to you a year ago, I told you that the government would provide access to primary care, and we have delivered on that promise. In 2 days' time, our package of initiatives will begin to help many thousands more New Zealanders to get the primary health care they need and deserve. Budget 2018 extended the very low-cost access fee to people who attend other practices and who are community service card holders. We estimate that will benefit around an extra 540,000 New Zealanders. They'll see on average a drop in their fee for a doctor's visit of $20 to $30. For community service card holders, we believe that that will not only mean a cheaper doctor's visit, in fact, it will actually mean a doctor's visit. For many of them, they just were not attending. And so I'm very proud of the initiative that we've made there, and that will kick in a couple of days' time. We've also extended free visits to 13-year-olds by adding one extra year onto the free visits for children scheme, and that will benefit an additional 56,000 children. These two initiatives required $362.7 million of new funding, and I know will have a major impact on people's health outcomes and lives. As I think I noted last year, the Families Package, which is now coming in, is one of the things that sits outside the health system that will have a huge impact. When that's fully implemented, a $5.5 billion package, when fully implemented, on average, families, hundreds of thousands of New Zealand families, will be $75 a week on average better off for people with a child in the first year of life, and it will be targeted to years 2 and 3. That will make a real difference too. In my letters of expectation to the DHBs, I have emphasised the need for collaboration across all parts of our health system to deliver affordable and accessible care, as well as improving the level and quality of services. And I do see a key role for clinical leaders such as yourselves in incorporating and sharing best practice and innovation across the entire system and supporting primary care to keep people well and their health issues well managed. The integration of primary and secondary care, you will all know, is a common challenge worldwide. It's an area where we do continue to be world leading. Professor Barclay's own DHB, the Canterbury District Health Board, has international recognition from the UK King's Fund for its model of integrating care. And I've seen examples in every DHB around the country of innovation we could learn from, but in that particular area, it's outstanding. When I spoke to you a year ago, I told you that there'd been underinvestment in relationships within the sector. And as Health Minister, I have made it one of my priorities to rebuild the relationships, and I've made my expectations clear to the Ministry of Health that it should do the same. I believe investing in these relationships is as important as investing in bricks and mortar. And the reports I have been getting back from the Ministry of Health, about the Ministry of Health actually, from the community that is accessing and into relating with the Ministry of Health, is that people do feel a corner has been turned. A turner has been coined. A corner has been turned. We really do have a ministry that is looking outward and engaging. I know it will take a long time to rebuild a ministry that had such a poor and unfortunate report card a year ago released by the State Services Commission that ranked it as I think it was about the second lowest ranked public service department, with a traffic light system that showed red lights for oversight of the sector, for relationships, for governance, and so on. And I am impressed with the new leadership and with the change that's happening. And I'm also impressed, and I just want to say thank you to all of you, because I know many of you will be engaging, with the spirit in which people are re-engaging with the ministry, are supporting the ministry to rebuild. It is incredibly important that we have a high-functioning and successful Ministry of Health for the future of our health system. So I want to say thank you to those of you who have re-engaged, even if in the past you've had less than adequate experiences. I also told you last year about the Coalition Government's commitment to initiate an independent inquiry into mental health within our first 100 days. We've delivered on that promise. Yesterday, I announced that I had formally received the report from the inquiry into mental health and addiction. It's going to help shape our country's response to mental health and addiction for years to come. The inquiry panel had over 400 meetings, received over 5,200 submissions, and their report is substantial and considered. I accept that it will actually take the government a bit of time to respond and digest and consider its 40 recommendations. We have announced already that we will respond to the inquiry next March, which gives us time both to absorb what's in there, but also enough time to be a bit clear about what we're going to do ahead of the next budget, because there are implications in there for our wellbeing budget in 2019. It will, of course, take more than one budget to address the issues we need to address in mental health and addictions. Those of you working in the area will be more than aware of that. We can all, of course, be justifiably proud of our health system's performance, but we can't get complacent or ignore the need to continue to do better. I recently acknowledged the 80th anniversary of our public health system, which began in earnest with the first Labor government and its 1938 Social Security Act. The practice of medicine and the services provided in today's public hospitals have changed dramatically since then. Wider societal changes and the pace of those changes will continue to put pressure on our system. We know we will need to continue to deal with the impacts of changing demographics. We will continue to have more people with more complex needs in an ageing population. We know we will need to continue to deal with the impact of changing technologies and the advances in what can be treated. We'll also need to deal with the expectations of New Zealanders, patients, whānau and communities, that they will be able to access the health services they require when they require them. It's a reasonable expectation and one that the government is committed to meeting. We need to do this in a way that is sustainable, both in terms of the overall cost and in terms of the demands placed on the workplace. It's against that background that I set up the Health and Disability System Review in May of this year. This major review is being led by Heather Simpson, probably most well known for her role as Helen Clark's Chief of Staff in the last Labour-led government. She is a health economist by training. She came into Helen Clark's office because she was a health economist originally, and she has relationships across the sector. She also has skills in marshalling well-informed and highly opinionated people, which I think will come in handy. It will identify opportunities, that review, to improve performance, structure and sustainability of our health system, with a goal of achieving equity in outcomes and contributing to wellness for all, particularly Māori and Pacific peoples. The review's interim report is due back to me mid-next year, and their final report by the end of March 2020. I'm hoping the review will chart a course for a fairer, more sustainable health and disability system that is well placed to respond to the future needs of New Zealanders. I really would encourage everybody to engage with that report. On the one hand, I'm very clear that when I look across at countries we like to compare ourselves to, we have a high quality health system that provides care in many or most cases more cost effectively than the countries we like to compare ourselves to. But there is not a clinician I have met in this country who doesn't think there are things we could be doing better, more sustainably, or achieving equity in a more effective way. So please do engage with that review. It is a once-in-a-generation opportunity in my view. It is one of the main reasons I put up my hand to take on the role of Minister of Health when I went round in opposition. Pretty much everybody I spoke to indicated a willingness and enthusiasm for change, and I think if we get this right, it is a real legacy that we can all leave behind to those who will inherit the health system from us in the future. So in conclusion, I do want to acknowledge my thanks to all of you for your commitment to our public health service. I want to thank you for your frank feedback over the past year, and I do look forward to working together to face challenges as we work to improve ongoing our public health system. I believe we all share the aspiration of a public health system we can continue to be proud of as New Zealanders, and that people can continue to be proud of this health system together. I'm sure the conversations you will have over the next 2 days of the conference, and no doubt those that will continue back in the workplace, will contribute towards these ends. Nō reira, tēnā koutou, tēnā koutou, tēnā tātou katoa. Kia ora koutou.
Thanks, Minister, and thanks again for taking time out of your extremely busy schedule to come and talk to us today. It's gratifying that the first topic that you started to talk about seems to be quite high on your list of thinking, is also the most important topic from our point of view as well, i.e. the understaffing, overwork, burnout, fatigue suffered by SMOs around New Zealand. And we've worked out we need 1,000 more SMOs very quickly to help deal with that. But what I want to do now is just take some questions. So we've had questions come up from the audience earlier, and we're just going to take those now, if you're okay to go through some of those. I'll read some of them out.
Yep, great.
So this question's from Heinz Stander from Tairāwhiti. Our research showing high rates of burnout among senior doctors and high rates of presenteeism, doctors going to work while sick because there's no one to cover for them. What is the government planning to do to address this beyond discussions? We've known about this for some time now. Is it time to see some action?
Yep. I can't account for the previous discussions that I wasn't part of before becoming minister and the progress or otherwise on them. But the commitment that the Director General has made to set up a forum to actually make sure that we look at concrete solutions is one that I'm thoroughly supportive of. And I would encourage you to engage with him. I think he's here, is it tomorrow? And give him a good grilling.
Okay. Thanks for that permission. Next question is from Julian Fuller, Waitemata. A senior doctor staffing accord has been proposed to ensure safe staffing levels in our public hospitals. Can you tell us where the proposal has got to and what your views on it are?
Yep. So at one level that's a conversation with the DHBs, but in another level I think the forum, again proposed by Dr. Bloomfield, will be a way of having that conversation around workforce issues and workforce pressures and how we map a path through. You will all know you didn't get qualified overnight. We can't magic extra people, but we do need a clear pathway to ensure that we do address burnout and staffing issues.
Thank you. This is a question from Bridget O'Connor in Auckland. She's a life member and former president of RDA. How seriously does the ministry take research on safer hours, fatigue, and the consequences therein? And I think Bridget wanted to just add some background to that as well. Is that okay?
Hold it closer. Hi. Thank you for being here and thank you for bringing up hours and fatigue and burnout. I think it's a really important question, and I think the reason I wanted to put some background in is I think we're in a pretty unique situation just currently in terms of what's come before and what's likely to come. We've got an RDA, as you alluded to, that's robustly argued for their members, particularly around limits on hours. At the other end of the scale, we've got SMOs who work with a contract where essentially there are no limits on hours. So we've got a changing workforce of doctors who are coming through having worked a different way and probably with an expectation of working a different way as SMOs. Now in the middle of that, we've got another group, the Stones, I don't know how they pronounce it themselves, but this new group of RMOs who have essentially undercut some of the work that the RDA have done around limits on hours. And they've recently agreed to a MECA with the DHBs that has different limits on hours. So I think there are some pretty big implications there. And I guess what I want to know from the ministry is, do they take the research around fatigue seriously? And what do they plan to do about it?
Okay, clearly that's a conversation targeted at the ministry, but I'll make some comments anyway. The first, my impression is yes, they bring those concerns. I make a habit of getting in the middle of industrial negotiations. So when a union, the new one that's been set up, Stones, seeks to form a MECA, I don't intervene and say you can't have a union. That just wouldn't be okay in my book. I have, however, sought some assurances around safety for my own benefit. And what I've observed in my limited engagement with it is that there are some additional provisions in their agreement that go beyond the RDA's ones. So they're different, but there are some additional protections in there. There are some things which the RDA will certainly robustly argue are better around safe staffing than the Stones one. That's a debate that has to be had, and the RMOs will choose which way they think is correct and which union is better serving their training needs, the clinical outcomes for patients and their ability to work with SMOs, as a general comment.
Thank you. This next one's quite long. Hopefully I get it all right. Julian Vyas from Auckland. International research shows New Zealand's health system performs well in measures of administrative efficiency and quality of care, but falls down on measures of equity and access to primary care and hospital care, including waiting times to see a specialist. We assume that the Heather Simpson review will aim to tackle these. People here face consequences of these systemic deficiencies every day. What do you consider as a reasonable time frame to significantly improve the situation given likely needs, i.e. increasing infrastructure and recruitment?
I agree with the propositions put there. I guess the thing I would say is that, firstly, I'm not going to preempt the findings of Heather Simpson in a year and a half's time, but what I would say is that I'm not going to wait for that to start doing some things. My letter of expectation is really clear around equity, primary care, and so on, some of those issues raised, that those are areas where I want to see improvement now. That doesn't mean to say that when we have structural change that won't mean further change, but I do think that there's room for progress there and agreement that we need to make progress in terms of equity, primary care and so on right now.
Okay. This is from Katie Ben in Nelson. Budget analyses show that we're about $2 billion short on operational funding compared to 2009-2010. Noting that we need around $800 million additional funding per year just to maintain the status quo, can we expect to see that funding shortfall restored in the coming years? I know that you've partly addressed that.
Yes, we have committed to, we thought that 2.3 billion was stripped out over the 8 years prior to the election, roughly, if you wanted to provide the same level of care with the same thresholds for care. That was the basis upon which the modelling was done. I think it was by either NZIER or one of the other independent, might have been Infometrics, that we had modelled that. That 2.3 billion figure, you can't take that much money out of the health system and not expect either a drop in services or pressure on the system. It just isn't possible. So we committed in the election to putting additional money in over coming years, partly to be very clear and send a really clear signal about our intentions as a government, because we believe that we need to restore funding that was taken out over time. You can't put it all in 1 year. You've got to train workforces, but we wanted to send a clear signal that we will continue to increase funding in the health sector, because you can see under the previous government, as noted, that as a proportion of the economy, health funding actually dropped under the last Labor government, not Labor government, under the last National government. It actually dropped as a proportion of the economy. And that just, it just doesn't happen in the Western world. Usually as economies get bigger, you spend a bigger portion of your available government spend on health, because without health, what have you got? But unusually, the proportion of the economy spent on health actually dropped, and so we're committing to growing that again.
Okay. Time's running on. This is the last question.
Yep. Sure.
This is from David Geller, former president. You've inherited a stable of rotten buildings that will cost us billions to refurbish. They're associated with the blowout and operational costs and contribute to burnout and disengagement. When it comes to new capital investment, what will stop the same from happening in the future? I know you've partly addressed that.
It wasn't in my speech notes, but I did partly go there with the National Asset Management Plan. That is what I see as the way of making sure we don't face the same problems in future, when it's transparent for all to see as to what replacement of buildings is going to be required into future years in order to maintain the status quo or to improve services. And it's a level playing field, independently assessed with benchmarking across the country. We'll be able to say, that this is the next logical one, that one, and this building has this lifespan, and we need to start planning for what comes after it. That's what we lack at the moment. It's been probably for political reasons, never been something that anybody's wanted to bring forward. I hope I've not been too naive, but I just could not wrap my head around the fact that a sector that has billions and billions and billions of dollars worth of buildings would not have a plan for how it was going to maintain and plan its future building. I absolutely think that's fundamental. It was something I did very early on, or demanded early on as a minister, and I honestly think of all of the different things I do, that will be something that will, I hope, have a long impact on our sector and in the public provision of healthcare in New Zealand. Thank you.
Thanks, Minister.
Thank you very much. Thank you all for having me here.